Hello and welcome to the HealthScore Longevity Report. This week we're going to answer the question, should you be taking a statin medication? Knowing whether or not to take a statin is one of a handful of modifiable factors that affect your risk of all-cause mortality. For a comprehensive assessment of all modifiable risk factors for all-cause mortality, check out HealthScore. HealthScore is a global assessment of modifiable risk factors. If you want to know your health score, I'm offering it for free. All you have to do is let me know and I'll send you the link. This week, we're going to answer the question, should you be taking a statin medication? We're going to answer that question with a review of two articles, both published in the Journal of the American Medical Association in August 2022. JAMA has an impact factor of 157, making it one of the best journals in the world. The first study was an updated evidence report and systematic review commissioned by the United States Preventive Service Task Force. And the second was a recommendation statement published by the task force. Some background. Cardiovascular disease is the #1 cause of death and disability in the United States. More than 1 in 4 adults die of cardiovascular disease. Cardiovascular disease includes coronary heart disease, when the arteries that supply blood to the heart get clogged with plaque, and ischemic stroke, when the arteries that supply blood to the brain get clogged with plaque. Statin medications are used to prevent cardiovascular disease, and they do so by changing lipid profiles as well as by decreasing inflammation and stabilizing plaques. This is an updated review of the evidence for the role of statins in preventing cardiovascular disease. The first review done for the task force was in 2016. It included 15 trials and showed a 14% reduced risk in all-cause mortality for those taking a statin medication to those who were not taking a statin medication. The previous recommendations published by the United States Preventive Service Task Force in 2016 and effective up until this current report were to prescribe statins for individuals age 40 to 75 if they had at least one cardiovascular risk factor, defined by abnormal cholesterol or dyslipidemia, diabetes, hypertension, or smoking, plus a 10-year risk of at least 7.5% of having a cardiovascular event. These recommendations were designed for individuals without a prior history of cardiovascular disease. Despite the recommendations for pretty widespread use of statins, statin use among eligible Americans is low. According to data from the National Health and Nutrition Examination Survey in 2013 to 2014, among those who are eligible to take a statin, use was for non-Hispanic whites 58.3%, non-Hispanic Asians 49.2%, non-Hispanic blacks 44.3%, and Hispanics 33.7%. This current updated report included 26 studies. 22 of them were randomized trials, including over 90,000 adults with follow-up periods anywhere from 6 months to 6 years. These studies compared statin versus not statin. One trial looked at different statin intensities, and 3 observational studies, including over 400,000 adults, reported any harms from statin use. The study population were adults age 40 or older without a history of cardiovascular disease event, but with at least one risk factor for cardiovascular disease. In 17 studies, there was a single factor examined. The most common factor was dyslipidemia, which was defined in various ways, but abnormal cholesterol. 3 studies looked at multiple cardiovascular disease risk factors, and a final study looked at people who had at least one of several cardiovascular risk factors. The results of this meta-analysis were that there was a decreased risk of all-cause mortality. This included 18 trials, over 85,000 adults. There was a relative risk of all-cause mortality of 0.92, which is an 8% lower risk of death for those taking a statin compared to those not taking a statin. The 95% confidence interval didn't cross 1, meaning that the results are significant. The researchers also asked, in addition to the benefit to the whole population, was there a benefit for people with higher risk of cardiovascular disease compared to lower risk? The researchers found that relative risk was similar, but absolute risk differed according to relative risk. The best example of this was the Jupiter trial included in the meta-analysis. People with a greater than 20% cardiovascular risk were compared to people with a less than 10% cardiovascular risk. And for those on a statin, those in the higher risk group had a relative risk of 70%, a 30% reduction in cardiovascular disease events. Those in the lower risk group had a 33% reduced risk of cardiovascular disease. So there's a similar relative risk reduction for both groups, regardless of their baseline cardiovascular disease risk. But the absolute risk difference, meaning the actual number of people who benefited, differed because the event rate was higher in the higher risk group. So 6.9 lives were saved per 1,000 persons in the high risk group, while only 2 lives were saved per 1,000 people in the lower risk group. The researchers also evaluated the question, was there any harm to the use of statins? They found that there was no significant difference for statin users in terms of withdrawal from the study, report of serious adverse events, cancer diagnosis, myalgias or muscle aches, elevated liver enzymes, or incident diabetes. None of these were increased in the statin group. It is important to go a little bit deeper into the question of diabetes because one of the trials did show an increased risk in diabetes. It's called the Jupiter trial. We mentioned it earlier when we were discussing relative risk and absolute risk difference. The study found that statin users had a 3% risk of developing diabetes compared to 2.4% for those not taking a statin. Taking a statin was associated with a 25% increased risk of diabetes. It was, however, the only trial that used a high-dose statin, and other analyses have shown that high-dose statins increase risk of diabetes. Furthermore, the researchers found that the risk of diabetes was increased only in patients who had baseline elevated risk for diabetes. Based on this report, which essentially showed a benefit for those age 40 and older with at least one risk factor for cardiovascular disease, and no significant harms from statin use, the United States Preventive Service Task Force has published new recommendations. These recommendations are essentially the same as the old recommendations. If someone is age 40 to 75 and they have one or more cardiovascular disease risk factor, like abnormal cholesterol, diabetes, high blood pressure, or smoking, plus they have a 10-year risk of 10% or greater, and additionally, even if they have a risk of 7.5 or greater, a statin should be considered. I keep referring to this 10-year risk. I'm going to show you now the calculator used to determine 10-year risk. This is published by the American College of Cardiology, American Heart Association. It's called the pooled cohort equation, and it asks for age, sex, race, systolic blood pressure, diastolic blood pressure, total cholesterol, HDL cholesterol, LDL cholesterol, history of diabetes, smoking status, whether or not on blood pressure treatment or on a statin or taking aspirin. And this instrument provides you with your 10-year risk. I do want to mention this is not the only guideline out there. The American College of Cardiology and the American Heart Association in 2018 published a guideline similar to this one, but a little more liberal in its recommendations for who is eligible for a statin. Similarly, the same age group, 40 to 75. Both agree that anyone with a 10-year risk of 10% or greater warrant a statin. But while the USPSTF is lukewarm about people with a 7.5% or higher risk, this guideline recommends, as strongly as they do for people over 10%, statins be prescribed to people at 7.5%. And they go further to say that even 5% or greater of a risk, 10-year risk, warrant at least a discussion of whether or not to take a statin based on the presence of other risk enhancers and on patient preference. Those other risk enhancers include metabolic syndrome, chronic kidney disease, inflammatory disease, and elevated lipoprotein A level. I do want to mention some concerns that were raised in the editorial to this study and recommendation, as well as some of my own concerns. One is that the recommendations, according to the USPSTF, are not to prescribe statins in people with a 5% risk or higher, but there is clinical trial evidence that people with a 5% 10-year risk or greater would benefit from a statin. The second is actually using these risk calculators. None of the clinical trials used a risk calculator to determine eligibility for inclusion in the study. So this is based on expert opinion rather than trial data. And it's a little counterintuitive to use a 10-year risk rather than, say, a cholesterol level. Statins are able to lower cholesterol, and providing statins to people with elevated cholesterol seems to have more face validity than calculating their 10-year risk. And an editorial uses the example of treating blood pressure. We don't treat blood pressure only when a person's 10-year risk is at a certain threshold. We treat blood pressure with blood pressure lowering medications independent of other risk factors. We treat someone who smokes and recommend smoking cessation not only when their 10-year risk reaches a certain threshold, but for anyone who smokes. And if we take cholesterol, LDL in particular, as a risk factor, we should be focused on that rather than a 10-year risk, which results in waiting longer and perhaps missing people with elevated cholesterol. The key takeaway from this study is starting at age 40, it's important to know your 10-year risk of cardiovascular disease and to get into a discussion with your primary care provider if your risk is 5% or greater. There is also benefit to further discussion of the use of statins, in my opinion, and in those of some of the editorial writers, that for those with elevated cholesterol independent of 10-year risk. My personal recommendation is to target LDL cholesterol in addition to 10-year cardiovascular risk, and to think of lowering cholesterol before age 40, and to think of lowering cholesterol first with lifestyle changes. These are topics I cover in other reviews. Thank you for listening. Have a great week.